many of you, is Jerry Sherman. And Jerry's going to be telling us about some emerging technologies in ophthalmic imaging. Just by way of introduction, Jerry's a distinguished teaching professor at the college. He has a very prolific career in writing and lecturing, particularly on recent developments in retinal imaging and the application to diagnosis of retinal disease. So without further ado, Jerry.
Well, thank you, David. Emerging Transophthalmic Imaging is the title. And I think we better go in the correct direction. We're going to begin with exploring the globe with technologies that image a mile wide and a mile deep. Let's initially begin with the anterior segment and go a mile wide. We now have the ability with UBM to look at this chunk of the eye. Pretty remarkable. And if a patient happens to have, let's say, a tumor here at the ciliary body, everybody sees a ciliary body on every patient? Probably not. We can now diagnose that. That one has actually a cyst, which you're not concerned about. But that one we get very concerned about. That one's actually a ciliary body melanoma. So we have technology that allows us to diagnose things that we really couldn't diagnose in the past. Let's really get the important stuff, the back of the eye, which I'm more interested in. The detection and diagnosis of retinal disease in visible ophthalmoscopy. This is really key to where we're going in imaging. Now, everybody recognizes this ophthalmoscope. Everyone's going to use it in the second week. And Helmholtz invented this 150 years ago. But it turns out it misses a lot. That's not what they teach you in the first 4 weeks of optometry school. But most disease begin at a level where we don't see it with a direct ophthalmoscope, or even with an indirect ophthalmoscope. And of course, the answer to this true-false question is false. Right? Everybody got that one, right? Spectral domain OCT has changed everything for us. There are lots of systems out there. You can't buy a bad spectral domain OCT. A lot of us have our favorites. It doesn't really matter. They all work extremely well. And what we find with spectral domain OCT that we didn't find before with time domain is a lot of detail that we never saw before. For example, the detail here. This line here called the PIL, photoreceptor integrity line, tells us about photoreceptors. I think all of you probably see all the cones and all your rods in all your patients on a daily basis. At least now we have a biomarker for photoreceptor integrity, cones centrally and rods outside of the central 1 millimeter. In some ways, this is actually better than histopathology, so getting additional information. How about this case? Well, this patient has reduced acuity, the fundus looks normal, and we can see that that PIL line is actually missing. And that's where the highest concentration of cones are. And if I told you this patient has achromatopsia, meaning either no cones or cones that don't function, you wouldn't be surprised. By the way, above the PIL, which is missing over here, we have the external limiting membrane that I never really thought had any great significance, except when we published this a few years ago, we noted that it was a little bit thicker on these patients with achromatopsia and also in patients with cone dystrophy. You can look at it vertically, get the same type of finding. Again, that's invisible to ophthalmoscopy, and it's very simple with a little bit of experience to pick this up. The vitreous, most of us don't really get a good look at the vitreous. This patient has vitreomacular traction, and you're probably not going to be able to see that with a direct ophthalmoscope. You can easily pick it up with OCT. I've seen some of the people in the room who've had this lesion. That's right, Richard, right? Thank you. Oh, I shouldn't mention it. HIPAA violation. In any case, we now have drugs which can prevent this vitreomacular traction from resulting in a macular hole, and that was just approved about a month ago. We also can get new vessels growing off the surface of the retina that we can see easily with OCT that we might miss completely with the standard slit lamp exams. For example, this is early diabetic. This patient has early proliferative degeneration, proliferative diabetic retinopathy, and that you're not going to see with an ophthalmoscope. Splits in the retina, we can get splits in the retina. Most of these are invisible to ophthalmoscopy. And that's going to affect vision, of course, because the PIL is affected, the photoreceptor integrity line. But we actually have seen now 27 patients who have splits in the retina, retinal schisis, around the optic nerve. And this can actually lead to, some of these patients have traction that could lead to retinal detachment as well. The whole world of autofluorescence that Diane actually mentioned is very, very important. This is a patient with a retinal degeneration. So left eye, here's the disc, here's the macula. Interesting shape. Let's turn the patient 90 degrees, or maybe just a slide 90 degrees. And the question is, what is autofluorescence all about? This will eventually develop a little dot over here, we think. The dark is hypoautofluorescence. This is dead retinal pigment epithelium. The bright spots over here That stands for hyperautofluorescence, where the retinal pigment epithelium isn't dead, it's just active. It's just sickened in a sense, it's metabolically active. Here's a patient I saw within the last 2 weeks. We've heard about my brother, interestingly enough, 7-year-old, 7.5-year-old with reduced vision, about 2100 or so. Fundus really looks pretty good. Here's autofluorescence, what do you think? That's normal here. That's hypoautofluorescence, death of the retinal pigment epithelium and associated photoreceptors. And all this is hyper. And these little spots, which aren't quite round but fishtail, tell us that this patient has Stargardt's disease with fundus flavi. Bilateral symmetric, yes. Here's what a normal OCT looks like on the right. Now, a patient here is 8 years of age. Well, the normal fundus is missing the PIL, photoreceptor integrity line. A lot of the other layers here are missing also, as well as the external limiting membrane, which is interesting, because I never really thought it had any great significance. Until 2 weeks ago, I looked at his sister, who's 5 years of age with no symptoms, and she has a hyperreflective external limiting membrane. Here's the patient, missing it. Here's mom, she looks fine, that's the PIL. And above that is this green external limiting membrane. But the sister clearly has an abnormal external limiting membrane. There it is. And does this photoreceptor degeneration that this patient probably has at age 5 result in debris accumulating on the ELM? And this novel finding may actually be a biomarker for very early degeneration. The good news is, or the bad news, she had a younger sister, 4 years of age, and we got a chance just a few days ago to see the younger sister. And sure enough, the younger sister also has a hyperreflective external limiting membrane. Both of these kids are probably going to go on to develop Stargardt's disease. Now, of interest is some treatment that we can talk about a little bit later that we might want to consider. Here's Dad. Dad and Mom are fine, but both youngsters have this hyperreflective external limiting membrane. This is a new finding. It's almost as if we're getting this debris that's sticking onto something that's structural, and then eventually you'll lose everything. You lose the debris and you actually lose the fence as well. But in reality, it may be a very, very early finding. Another technology which is interesting, here's a patient I got to see who came in with 20/20 visual acuity, no real symptoms, and of interest she had this systemic disease that you knew about, neurofibromatosis type 1. And I did standoff ophthalmoscopy on her with binocular direct, and she was fine. However, then we went to something called multispectral imaging, where we used actually 10 different LEDs, light-emitting diodes. And generally, this is a photoluminosity curve peaking at 555. Fundus photography is made to pretty much tell us what we see with the direct ophthalmoscope. However, there are a lot of things that may be going on over here at these wavelengths that we miss. So this patient looks normal with green, yellow, and amber, but as soon as you get into the red and the infrared, this patient has a remarkable number of spots which match what she has going on her skin. Again, normal here, and as soon as you get down into the red and infrared, remarkably abnormal. Here's the left eye. So here's another new technology. Rather than using just a fundus camera taking one picture, we'd rather use multispectral imaging to go deeper into the retina and into the choroid to find the things that are actually invisible to ophthalmoscopy. Another patient with a normal-looking fundus, 27 years of age with symptoms, 20/20 acuity, but he says he's having difficulty reading. What does he show on autofluorescence? Well, bilateral bullseye maculopathy. Now, the etiologies of this could be cone dystrophy, but his color vision is normal, as is his photopic ERG. Then it could be plaquenil toxicity that Diane just mentioned before, but in reality he's never been on plaquenil. It turns out he has Accutane toxicity, most likely. So that's the only drug that we know about, besides the plaquenil, that can actually do this, and happens to be the patient who was on Accutane. If we look at his OCT next to a normal, we can see he's missing a lot of tissue also. The reason why he has 20/20 acuities was the PIL is still intact under the fovea, but there is a field defect if you do microperimetry right around the fovea. And just blown up, a normal PIL, external limiting membrane, here's our patient. The PIL is present, hence 20/20 acuity, but on microperimetry does have a field defect very close to fixation. Here's a patient I just saw a couple of days ago for the second time, and she's 25, and her complaints relate to difficulty working on a computer. She just wants a new pair of glasses. She has a funny floater. However, when we go to autofluorescence, looking at ultra-wide field autofluorescence, she has this amazing lesion, which is present in both eyes, which looks a lot like a retinal degeneration, except this kind of a pattern hasn't been published. So it is a form of retinal degeneration, even though she didn't have any of those symptoms. Here's a standard OptiMap that did that usually takes images of ultra-wide field. The new Daytona we now have in the building for, I think, 11 days or so, is capable of doing these kinds of images through an undilated pupil. About 2 millimeters is all you need to actually get an image. It only takes about a minute. The same system will be updated because there's place for it to actually do fluorescein angiography. You can do fluorescein on a much more expensive system that we actually have in my office. And this patient has sickle cell. And if we go ahead and look at the central retina, it's fine. Look at all the stuff going on in the peripheral retina. And I think everyone can see on the fluorescein these new blood vessels growing on the surface of the retina. And you can see they're obviously leaking. And here we have areas of capillary avascularity. And we can do that over time, of course, as we typically do. Another patient with a normal posterior pole with 20/20 acuity and no symptoms has a Coates-like response with areas of avascular. You can see the avascular capillary zones. And over here on late stage, you can see it leaks. Of interest, this patient nasally, if we look out, just to give you some sense of what we can actually do with technology today, we can get out to very, very fine vessels, in focus in the periphery. Everything's in focus at the same time, interestingly enough. And these are probably about 7 microns in size. So I just got something from Dan I have to finish up. Great. How about this? We see this all the time. Hemorrhages. With our new Daytona, we saw that 3 out of the first 10 patients had little peripheral hemorrhages temporally. And the question is, what are these? And that's something that we're actually very interested in trying to research. How about this patient? Large lesion here, and 5 little lesions. What are those small ones? The big one's a retinal schisis. How about this one? Well, if you do an OCT through it, you can see the schisis. You can actually see that that's an outer retinal hole. Retina is missing over here. Don't be surprised that within you're going to see systems that do ultra-wide field photography with OCTs within the same system. That's coming. And electrical imaging, multifocal ERGs, was mentioned before in plaquenil toxicity. And also, we have the ability of doing electrical imaging, look at the entire visual pathway with VEPs. Virtually everything I just mentioned is in Retina Revealed, free, www.retinarevealed.com. We're up to about 2,700 images, and it costs nothing to get on it, unless you decide you want one of these instruments and you buy one. Then all of a sudden it's not free anymore. Thank you.